Hi, I'm Dr. Joe Jabre. I'm a neurologist and I specialize in EMG. EMG stands for electromyography, which loosely translated means electrical testing of nerves and muscles. The nerve is like an electrical wire. So basically the way we test it is the same way an electrician tests an electrical wire. We run electricity through it. When the electricity goes through the nerve, we can see if it's getting stuck somewhere, if it's slowed, if it's not working at all, and so forth and so on. And basically we can determine where it's stuck or where it's slowed, how badly it is, and so forth and so on. Now when we stimulate the nerve, we can record either from the nerve directly or from the muscle that's innervated by the nerve. Why is that? Because the nerve contains, most nerves contain both sensory and motor fibers. Needless to say, the sensory fibers are the ones that bring the sensation from the fingers or the skin or the leg back to the brain. The motor fibers are bringing the brain signal down to the muscle to move it. So whenever you're stimulating a nerve, most of the time you're stimulating both nerves that are sensories and nerves that are motors. It really depends on where you are recording from. So for instance, if we are recording from the finger and we're stimulating the median nerve here, but recording from the finger, we're recording from the sensory fibers. If we stimulate the nerve and we record from the muscle, we're recording from the motor fibers. So it really doesn't matter where you stimulate. Actually it does, but what matters most is where you record from, because that's what it's going to determine if you're studying sensory or motor fibers. Now, what are EMGs useful for? EMGs are useful for a lot of conditions and a variety of problems that affect the nervous system. The ones that you've probably heard most about is carpal tunnel. A lot of people have carpal tunnel with hand numbness and tingling and sometimes weakness, patients with low back pain, patients with diabetes who get diabetic neuropathy. For all of these conditions and others like trauma and injury and neck pain, a lot of physicians order nerve conduction studies and EMG testing because they want to see if the nerve is impaired, is damaged, how bad, and where it is impaired. So in order to do the study, we use an EMG machine, and here you have an EMG machine that's it next to a laptop. The laptop really has the programs that run the EMG machine, but the EMG machine feeds the signals that we get from the patient or the subject into the laptop, and the laptop analyzes those. So what I'm going to do first is to show you a little bit some of the paraphernalia that we use for nerve conduction study to get you a bit used to the terminology that we use. First of all, there are electrodes. These are the electrodes that we use to record from muscle or nerve. Okay, you can see there are 3 of them. You can see they're color-coded. There's the green, the black, and the red. The green is for the ground, obviously. That's just to shield the patient and to get a nice stimulus and without artifact. The black is to record, is called the active electrode, and that's basically you put it where you want to record from, whether nerve or muscle. The red is called a reference electrode. That means you put it somewhere that is normally neutral so that the black electrode can refer to it and say, what is neutral? And it says, well, this is neutral, so therefore it can read the actual activity of the muscle and nerve. Now let's look at the EMG machine now. You can see it has a lot of knobs. I'm going to go over most of them when we do this. But some knobs, when you push them, is just to stimulate, to trigger the stimulator. This is a stimulator, right? And the stimulator also has 2 electrodes here, a positive and a negative. And basically when we push one of these buttons, it emits electricity and the nerve or the muscle gets stimulated, or both. Then there is some knobs to analyze the signal, to put the cursors to determine where it started, where it stopped, and so forth and so on. Then obviously you also need to deliver different kind of and different levels of stimulations. Let me explain to you why that is. Let's say that this is a nerve and it has 10 fibers inside of it, right? If you use very little electricity, you're going to just stimulate 1 or 2 or 3 fibers, or maybe no fibers whatsoever. So if you use very little electricity and stimulate, let's say, 2 or 3 fibers, you're going to have a very low amplitude, and that you can interpret it as abnormal because that's not the whole nerve activity. So basically what we do in this study is raise the electricity until we stimulate all the fibers in the nerve, and that means when the amplitude of the nerve stops growing. Whenever it stops growing means you've reached maximum. We do this, by the way, for the sensories and for the motors. And once you stimulate the nerve, you obviously have to record, either from the nerves or the muscles, and the recording goes in the machine sends it to the laptop analyzes it, sends it back to the machine. That's how that works. The next thing I'm going to show you is how the laptop controls the machine with the program and so forth and so on. But before I do that, I want to show you what I keep with me all the time by my side. I have this laminated sheet that shows you all the nerves that we study in the arm and the leg, and the distances that we use and the positions of the electrodes. And this book, which goes over the anatomy, explains how we explain the test to the patient, shows you the setup for the median sensory, for the ulnar, for the radial, gives you normal values, and shows you the position of the stimulated electrodes. So basically what I want to impress you by is always have these resources nearby, so that if you forget something, or if you want to try something different, you can always refer to it and see if it's working well or not. All right, now let's get to the laptop. The laptop, as I said, has a program that runs the machine and analyzes the signals. So let's get started with this. We're going to start the program. And the first thing it's going to do is going to come up and we're going to say, I'm going to do a new exam. And it's going to ask me for the patient's name. And by the way, this is Samantha Joy. And last name is Joy. Okay. And first name is Samantha. She's a female. And birth date is
9/17/1987.
9/17/1987. Okay. And about how tall are you, Samantha?
5'3".
Okay. 5'3", just have it here. I have this sheet in front of me, which tells me that 5'3" is 160 centimeters. Everything is in centimeters today, so you really have to have this sheet in front of you to know the correspondence between feet and centimeters. About how much do you weigh?
118 pounds.
Let's say it's about 50 kilos. Okay, the department, let's say it's neurology. And you can say diagnosis, carpal tunnel. Let's say I think she's normal. This is the first time she's having this study, but I just want to put a diagnosis. Okay, and now we can start with templates. And here, all a template is I tell it, this is what I want to do first, this is what I want to do second, third, and so forth and so on. So I don't have to restart it every time I do it. And I'm going to say I use a left arm nerve conduction study. And that's it. And I put this information, and the screen is going to come on. I'm going to go over a little bit what you see here. The first thing I'd like you to see is that it's saying, median sensory left. That means that's the nerve that we're going to be studying. Okay, then it's going to show you a whole bunch of numbers. Stimulus, 2 milliamps, duration, 0.10 millisecond, and frequency at 2 hertz. I will explain that to you in a minute. This is the screen that's going to show me the potentials when I studied them. And this is the screen here that's going to show me the amplitude, the latency, the velocity of the segment. So each part of the screen shows you a little bit what you're doing in terms of the stimulation, the recording, and the analysis. So that's the screen that we're going to be working with. Now, what do we study in the arm? What are the nerves that we study in the arm? What are the nerves that we study in the leg? Clearly, in order to be able to study a nerve, you have to be able to stimulate it. So the nerve has to be close to the skin in an area that's far enough away from other nerves in the skin, because otherwise you don't know what you're stimulating. And we have to be able to record from a muscle that's away from other muscles, or a nerve that's away from other nerves. This way we know what we're stimulating and what we're recording. Of course, the reason we do all of these things is to investigate the symptoms that the patient has. Most patients come with carpal tunnel, low back pain, neck pain, diabetic neuropathy, and so forth and so on. So we need to isolate some of these nerves that sort of give us the biggest bang for the buck. In the arm, there's the median nerve for carpal tunnel. There's the ulnar nerve for ulnar neuropathy at the elbow. You know when you bang your elbow and hit the crazy bone. And the radial nerve, which gives you a weakness in the arm, in the hand. In the leg, you got to study a lot of muscles that have to do, a nerve that have to do with low back pain. And for those are the sciatic nerves. Those are the peroneal and the tibial. And the sensory branches, the sural and superficial peroneal. Now, that doesn't mean that you do all of these nerves all the time, but that does mean that these are the nerves that you should study most commonly, because that's what actually gives you a lot of information about the clinical symptoms that the patient is complaining about. Now, one important thing, which you really should pay attention to, is public enemy number one is cream on the legs. We always call the patient before they come in the next day, especially women, and say, don't put any cream on your legs, because the study is going to be okay, but the problem is the electrodes are not going to stick. And so you're going to have to spend a lot more time putting electrodes, taking them off, putting them on, taking them off, so forth and so on. The second problem is if you have cold hands or cold feet. That will really mess up your study. It will make it look abnormal. So I always have a hair dryer with me that I do for about a minute or a minute and a half or 2 minutes for the arm and the leg, if they're cold, obviously, to make sure that the extremity is warm before I do the study. So now we're going to get ready to do the studies. As I said, in the upper extremity, we're going to do the median nerve, the ulnar nerve, and the radial nerve. Now, before I start the study, what I like to do is to measure and to make sure I use a pen to mark up the spots where I'm going to put the electrodes. It's much simpler to measure and to put this, mark up the spots where you're going to put the electrodes in the beginning, because you're going to be using cream. By the way, speaking about cream, we use cream gel that has salt in it. Do not use ultrasound cream, because it doesn't have salt and it will not conduct. So because we're going to put cream, you know, it's going to smudge the places where we're going to put the electrodes. So I always like to mark it up first before we start using the cream, and then put the electrodes later on. So the median nerve, first nerve that we study, innervates the thumb, index, middle finger, and part of the ring finger. And we usually study the index finger for the median nerve. And to mark it, I will mark on the place where I'm going to put the electrode. I put it here. For the active electrode, the black, I put it here. For the reference electrode, the red. For the ulnar, I put it here. For the active, I put it here for the reference. And now I'm going to measure. Here's this nice ruler that we've created just for that. And this nice ruler has the measurements that we use for each one of these nerves. Now, why do we use measurements? Simple, because if you're stimulating a nerve from far away, you're not going to get as good a response as you are going to get it from closer to the recording electrodes. So you have to decide what is the distance that you're going to use in order to do that. In order to find out if a response is normal or abnormal, you're going to compare it to some normal value. Now, in order to compare it to a normal value, you have to study the patient just in the same way that you studied the normal subject, to make sure you're comparing apples to apples and oranges to oranges, not apples to oranges. So for that reason, we use standard distances. And in here, it tells you the median standard distance is 13, the ulnar is 11, the radial is 10. All they mean is that we use the same distances to do normal values. So I'm going to put the 0 here. It's in centimeters, of course. And I'm going to see that the 13 centimeter point is here. So basically what I'm going to do is I'm going to mark up the spot here. And that's where I'm going to stimulate the median nerve. For the ulnar nerve, it's going to be 11. The ulnar nerve is on the side of the wrist. Mark up the spot. That's what I'm going to stimulate for the ulnar nerve. Now for the radial nerve is really at the bottom of this V between the index finger and the thumb. So I mark up the place where I'm going to record from. And it's 10 centimeters above, right over the bone. All right, so the first nerve we're going to study is the median sensory, and we're going to do the median sensory on the left. So we're going to take some electrodes. These are surface electrodes. And I'm going to put them right where I marked up the spots. This is for the active, that means the black. By the way, you can use the same electrode on the same patient. You don't have to use different electrodes all the time. If they don't stick anymore, you can change them. So active, reference, and then, of course, the ground, which I'm going to put here. How do I know which one is active, which one is reference? By plugging the black into the active. by clipping the red into the reference, and by clipping the green into the ground. And now I can stimulate the nerve, and you're going to see some activity that's going to appear on the screen. The median nerve, I marked it up here, and these are the sensory fibers. I'm over the nerve, I'm not over the muscle, so these are the sensory fibers. I put some cream over the stimulator, and I start stimulating. In the beginning, she's not going to feel anything. Now pay attention to this. This is the stimulus. As I increase it, she's going to begin to feel something. And again, I need to increase it enough that I know that I've stimulated all the nerve fibers. And I know this when the action potential stops growing, when the signal stops growing. So basically, I'm going to start with maybe 6 or so. And here we go. I'm going to stimulate the nerve. I got a response even earlier. So I'm going to show you something that has no response. So now that I didn't stimulate the nerve, okay, I get a flat because I'm having a very, very low amplitude stimulation. Now, as I raise it up a little bit, I'm starting to get a response. By the way, this purple is the previous response. So that to show you what it used to be before. So now when I press this button again, this green one is going to become purple. I'm going to acquire a new one. So I'm going to increase the amplitude of the stimulation a little bit. And again, it's growing. See now how much it grew from the purple to the green? Going to go up a little bit further. It's growing further. Going to go up a bit further. And you see now the green and the purple are completely superimposed. That means that's maximal. And I can stop. And that's the median nerve. Now, let me show you what we measure in the median nerve. Now that I'm stopped, I tell the machine that I'm stopped. And the machine is going to place the cursors. And these are these numbers 1, 2, and 3, and so forth and so on. These are the cursors that we place on the nerve. This is actually when we began the stimulation. This is here, right here is where the nerve started to respond. Okay? And so it took this long from here to here for the nerve to be stimulated. Now, you see these yellow crosses here, plus signs? It says here that they are 2 milliseconds. That's the scale. From here to here, it's 2 milliseconds. From here to here, it's 2 milliseconds, 2 milliseconds. It's actually 2 milliseconds for division. So I can already guess that it took about 2 milliseconds, maybe slightly more, but not a lot more than 2 milliseconds for the stimulus to reach the nerve and depolarize it. Then the nerve is depolarized, goes up like this, and that's the peak of the nerve. That's the highest amplitude of the nerve. And then the nerve goes back and goes back down, okay, and then returns to baseline. Forget about this bump. This is because the finger was moving. So that's the sensory action potential. And now I would like you to look here. You see that the stimulation point from the wrist here, the distance that we used was 130 millimeter. The latency is 2.25 millisecond. So actually this is a little bit over 2. So 2.25 millisecond. The amplitude is 24.2 microvolt. The duration, area, stim, that's not important. I'm really mostly interested in the latency and in the amplitude for the sensory potential. And that's the median sensory potential. So now that we finished the median sensory, we're going to go to the next nerve. And all I got to do here on the machine is press on the next site. When I do this, you're going to see on the screen the ulnar sensory left appear. That means I'm ready to do the ulnar sensory left study. By the way, the machine is going to keep this nerve stored here, so I'm not going to lose it if I go to the ulnar. So I press next, and now the ulnar sensory left, and the screen is blank again. That means I can start from scratch to do the ulnar. And what I'm going to do, ulnar, as I said, is over the baby finger. So I take this electrode off like so. These are they stick nicely so that you can do a whole study with one set of electrodes. So I'm going to put this over the ulnar here. Okay, that's for the active. Take this one off and put it over the reference, like right here. Okay, and I'm going to leave the ground exactly where it is. Now, I'm put a little bit more cream. Don't put too much cream, because sometimes what you do is you make a cream bridge. That means there's cream between this electrode and this electrode, and you're going to short circuit. Nothing's going to happen to the patient, but you're going to short circuit the signal. You're not going to get a good response. So be very careful on how much cream. Not too much and not too little, obviously. I stimulate the ulnar nerve over this area of the wrist right here. Okay, and now I got to go back again here. If I press it at a stimulus of 2 milliamps, okay, I'm certain that I'm not going to get a response. So that's why I go up. I'm going up to 8. And 8, I'm beginning to see a response. Look at that. Beautiful response at 12. Now I'm going to see if I can get it higher. Remember, I need to get it as high as I can so that I know that I stimulated all the nerves inside that nerve, all the fibers inside that nerve. And here, and actually that's not growing anymore, so that I know that that's the maximal response that I'm going to get. Now I'm going to store it, and again, you see a nerve action potential. It put the machine automatically places the cursor. Now sometimes the machine does not place the cursors in the right place. Sometimes the machine might place the cursor here. I'll bring it down so that you can see it. Sometimes the machine might place the cursor here, and I know that that's not the right thing. It's using some formulas to put the cursor where it thinks it is. So I can override it and put it right where I want it. Again, what I want to show you, for instance, I don't like this cursor here. I'm going to bring this cursor a little bit down here. And I want to show you here, this is the sensory potential. Not this, not this, not that. Why are you getting this red back and forth here? Because as you're stimulating, the finger is moving. When the finger is moving, the electrodes are moving, so you get a stimulus shock movement artifact, basically. And we ignore that. And what I want to tell you is usually the sensory action potential is usually in the second and sometimes in the third column, but not further than that. So now we know that the onset latency, that means the distal latency, that means the latency when the nerve started to react to the stimulation. The latency is right here, number 1. The one that's put at the peak, obviously, it's called peak latency. Now, why do we measure 2 latencies, onset and peak? Because sometimes the nerve gives you a lot of artifact, and sometimes you can't really tell exactly where the onset latency is or the distal. I'm using onset and distal interchangeably. Onset and distal is the same, where the distal latency is, but everybody can identify where the peak is, so sometimes that's why sometimes they use the peak latency. And now they use the return to baseline. That's number 3. Now we talked about latency and amplitude, and the next thing we need to talk about is velocity. So let's talk about velocity now. Let's look at this here. It says the latency is 1.75 milliseconds. So that's, remember the median was 2.25? Okay, so this is even earlier than the median. It started at 1.75. And the amplitude is about 26.1 microvolts. The amplitude of the sensory action potential, by the way, is measured in microvolts, in the, which is one way of measuring the sensory action potential. The amplitude of the motor action potential coming from the muscle is in millivolts. Okay, so now we have the latency 1.75 millisecond and the amplitude 26 microvolt. Then if you look at the right here, it says sensory conduction velocity. You see it says the distance is 110 millimeters, like 11 centimeters, and the time it took was 1.75. That's the distal latency. The velocity is 62.9. Now, how did we arrive at that? So basically, I'm saying the nerve took 1.75 milliseconds to be depolarized, to be stimulated from when I stimulated here. So the moment I stimulate here, from here, it takes the electricity 1.75 milliseconds. That's 1.75 1,000th of a second. It's extremely fast. So it took the electricity 1.75 milliseconds to travel from here to here. Okay, if that's how long it took it, how much distance did it travel? The distance that it traveled is 11 centimeters or 110 millimeters. So I divide the distance by the time, and gives me a conduction velocity, which essentially is a speed. So the speed of conduction of that nerve is 62.9 meters per second. That's called conduction velocity, or the speed of the nerve. We're done with the ulnar nerve, so now we're going to do the radial sensory. Again, all these are the sensory studies. We're going to do the motor studies next. So I'm going to press next here on the machine, and that's going to take me to the next nerve, which I set up. I want the median first, the ulnar second, the radial third. So now I get the radial sensory. I can choose another nerve if I want, but if I just want to do that, I press next, next, next. And of course, what I will do is I will take the electrodes off here. Okay, I'm keeping the ground exactly where it is. I don't need to move it. And remember, the sensory for the radial was here, so I'm going to put the active electrode here, the black. I'm going to put the reference over the thumb here. Okay, and I'm going to stimulate right where I marked it for the radial nerve. And I stimulate it like so. Same thing. Look at the screen now. No response. Okay. I start going up. I get a very nice response. Going up some more. What I'm looking at, are they the same size or not? And actually they are the same size. Here we go. Okay. And I accept that. And then it's going to measure, as you saw before, it measures the onset or distal latency, the peak latency, and essentially the return to baseline here. And it tells you the onset latency is 1.65. Did you see here? The median, I used 13 centimeter distance. The latency was 2.25, so it took 2.25 milliseconds. For the ulnar, if I recall correctly, it took 1.75, but I was working at 11 centimeters. And for the radial, it's 1.65 because I was working at 10. So the further away, the longer the latency. Now, why is that important? That's important because if you do the median at 15 and you compare it to a 15 centimeters distance and compare it to a normal value that was done at 13 centimeters, it's going to look abnormal because 15 takes longer to get there than 13. That's all there is to it. It's no magic. So it tells me that the latency is 1.65, the amplitude is 26.2, and I tell the machine I used 100 millimeters, 10 centimeters or 100 millimeters. It tells me, well, it's conducting at 60.6 meters per second. And that's normal for sensory conductions. We're done with the sensory studies, so let's now do the motor studies. We do the median and the ulnar. For the median nerve, we record from the abductor pollicis brevis muscle. We call it fondly the APB. Abductor pollicis brevis, abductor means it spreads. Pollicis in Latin means thumb. Brevis means short, because there's a long abductor and there's a short abductor. The abductor pollicis brevis, the APB, is right here. It's really in the palm of the hand, right here. It's called the thenar eminence. Okay, so I need to locate the muscle first, obviously. So push your thumb against my hand to the ceiling. And you can see how the muscle is bumping up here. Now relax. Now push it up again. Now relax. So now I see where the muscle is. So what I'm going to do is mark up the muscle, which is about, push up again, which is about right here. Okay. And I'm going to measure 5 centimeters. Again, remember, it's not important what distance you measure as long as you measure it consistently the same and the same at which the normal values are obtained. If you've already been doing these studies and you measure those at 7 or 8, that's okay if you're comparing it to 7 or 8 normal values. It's okay. So I push here and I mark the 5 centimeter point. Then I like to do the ulnar at the same time. And the ulnar we record from the abductor digiti minimi muscle, and that's the muscle really here on the side of the hand. Abductor means it spreads, digiti means finger, minimi means small. So it's the muscle that spreads the small fingers. Spread your fingers. And here I see it, I don't know if you see it well here. The muscle bumps up here, and I put it across here. That means that's when I'm going to put the surface electrode. I measure 5 centimeters here, and now I know where I'm going to stimulate it. So again, these are my distances because I have good normal values for them. Now I've accepted that, and now you see that the computer has put the cursors here. Again, it's the distal latency. Okay, let's read it. It's 3.35 milliseconds, so it takes longer for the muscle to depolarize. Why? Because there's neuromuscular transmission and there's muscle fiber conduction. So the electricity is traveling from here, it's crossing the synapse, neuromuscular transmission, it's going to the muscle fiber, and now it's recorded from here. It takes about 3.35 milliseconds to travel. So that's the distal latency or onset latency. And here the 2 is put at the peak of the potential to measure the amplitude, and 3 is put at the return to baseline. And again, if I don't like these positions, I can always change them, but they look okay to me. And so basically I'm reading that the latency is 3.35 and the amplitude is 6.78. So as I said, for the muscle, for the motor conductions, we do 2 stimulation points. The second stimulation point for the median nerve is going to be at the elbow. So now let's stimulate the median nerve at the elbow. That's the second stimulation point. Because as I said before, for the motor nerves we do 2 stimulation points. For the sensory nerve we do just 1 stimulation point. And at the elbow, the median nerve is located right. If you ask the patient, the subject, to bring your arm up, bring it up, pull up, if you feel the biceps tendon, it's right on the inside of the biceps tendon, or right over the pulse actually. If you put it over the pulse, you're going to stimulate the median nerve. So put your arm down, and I put it here. Now your arm is going to jump, okay, because I'm stimulating the nerve with a whole bunch of muscles that are inside the forearm, so the arm is going to jump. So two important things. One is that you need to see a potential that looks almost the same as this one, because if you don't, that means you're stimulating another nerve. So the nerve from the wrist stimulation and the nerve from the elbow stimulation have to be very similar. Now the wrist stimulation, because it's very close to the nerve, is going to give you a high amplitude. The elbow stimulation is going to give you a slightly lower amplitude, not too much lower. Because if it's too much lower, it's going to be abnormal. But a lot of times I find them almost the same. But normally it will be slightly smaller, and you will see that. Maybe you will, maybe you won't. So now what I'm going to do is I'm going to stimulate here. And again, the subject will, the arm is going to jump a little bit. So here we go. I stimulate. And the arm jumped a little bit. And look, it's perfect. It's beautiful. It's almost the same. I'm going to stimulate a bit more to see. And the arm jumped, and I don't get any difference. So I accept that. And look what we see now here. You see the wrist stimulation and the elbow stimulation. They look almost the same. Okay. Their amplitudes are very, very similar. And now the computer marked up the onset latency for the motor, the onset latency for the wrist, the onset latency for the elbow. This is called a distal latency. This is called a proximate latency. Distal latency, that means distance from the spine. Proximal latency, that means closer to the spine. So why do we get to point? Because we want to do a conduction velocity between this point and that point. So basically, when I stimulate the nerve here, the electricity goes from here all the way to the muscle and depolarizes the muscle, stimulates the muscle. When I do it from here, it goes all the way from here to the muscle and depolarizes it. Now I want to calculate a conduction velocity or a speed between here and here. Not between here and there, but just between here and here. So what do? What I need to do is, from here, it's going all the way to the muscle, so that latency is all this. This latency is just that. So if I just want this, I need to take this portion of the latency from this portion of the latency, and so I subtract the distal latency from the proximal latency. Again, this is the whole thing. This is part of it. So if I take this portion out, now I have the latency between elbow and wrist. And that tells me that the distance between elbow and wrist is going to be the distance at which I measure conduction velocity. And in this case, it's 23. Okay? So now the computer has told me that if you look at this here, the latency from the elbow is 7.3. The latency from the wrist is 3.35, and it's going to calculate the difference between the latency from the elbow and the wrist. And if I give it a 230 millimeters, 23 centimeters, 230 millimeter distance, it's going to tell me that the conduction velocity is 58.2 meters per second. So that's how I calculate the conduction velocity from elbow to wrist. Okay, we're done with the median motor study. Now we have one more study we need to do with the median, and that's the F wave. Let me tell you a little bit about the F wave. The F wave is a very, very small wave that actually comes from the spine, travels up from the wrist up all the way to the spine and comes back to the muscle. Now let me tell you how that happens. If you're stimulating a nerve here, okay, the electricity is not just traveling this way. The electricity is traveling up this way and down this way and all over the nerve, essentially. So you're stimulating the nerve everywhere when you stimulate the nerve. Here, electricity travels up and down. Okay, let's say that this is the spine and this is the hand here, the wrist. Okay, if I stimulate the nerve here and I'm putting the recording electrodes from the wrist, I'm going to study the nerve from here to here. But if I'm stimulating I'm stimulating the nerve here, okay, and the electricity is going up and down, I'm also going to record the response that goes up the spine and comes back. So if I use the right kind of electricity and the right type of display of the signal, I'm going to see a very small wave, which is called the F wave, because it was discovered in the foot in the beginning. Then they found out it was present elsewhere, so it was called F wave. So if I use the right stimulation tools, and if I display the right display of the screen, I'm going to see a very small wave that comes after the motor response that we have just seen, after this here, okay, and that's going to be the F wave. The nice thing about the F wave is, since it comes from the spine, it tells you if there is a disc disease or a disc herniation. So patients with low back pain or neck pain, the F wave is very useful in. By the way, the F wave does not exist in the sensory nerves, but it does exist in the motor nerves. Actually, we can just stop the median nerve now and go into the F wave mode. And you see that the display changed a little bit, and I'm going to show you what that means. It says median F left, and now I'm going to stimulate the median nerve at the wrist for the F wave. I don't change anything, okay? I just put the stimulator like this. I leave the electrode exactly where they are, and as I said, the electricity now is going up and going down, but I'm going to analyze what went up this time. So when I stimulate this, I'm now paying attention to what's going up, and here we go. I'm going to give her some electricity. So on this side, you're going to see what's coming from the hand. And on this side, you're going to see what's coming from the neck. So here we go. You can give her a stimulation. You see what's coming from the hand here. I'm not giving her enough electricity, so I don't see anything coming back from the neck. So I'm going to go up. Now I'm beginning to see maybe a little bit of wave coming from the neck. You can see it here. You're going to see it better in a minute. Here we go. Now, with the F wave, it's very important to distract the subject while you're doing this, because it might have some reflex responses in it, and when you distract them, you can get a better response. So let's try this. Here's a little ball here that we use, and we ask the subject to squeeze it. Basically, that's all we do, okay, and that distracts them. So grab this, and obviously have them squeeze it with the right hand if you're doing the left, with the left hand if you're doing the right, and that distracts them, and maybe that gives us some better responses. So let's do that again, and make sure that you continue squeezing them as much as possible so that we can see the responses, okay? So let's see here, and we're going to begin to see a good response. Okay, so now that we got some responses, you see here on the right side, we know that the left side is working. We're not looking at the right side. The right side is coming from the neck. So let's do this here, and we start stimulating. I'm going to give you about 10 shocks, because I'm going to see which one is the best one for me to measure. And the best one is the fastest one, so the one that has the shortest latency. Here we go. 1 shock, 2. Nice F wave here. You see that? Because she was squeezing. 3, 4, very nice one. 5, 6, 7, 8, 9, 10. Thank you very much. That was great, and that squeezing really did it. So now I'm going to analyze them, and the computer now here is superimposed them, and it just tells you that the shortest latency F wave is probably this one right here. the computer automatically measures it and gives you a shortest latency F wave, and that's how we know that this is the fastest conducting fiber. And if it's abnormal, it's going to be slowed. If it's normal, it's going to be normal. It's going to have normal latencies. So again, the F wave is coming from the neck. On the left side, you're seeing what's coming from the wrist. On the right side, you're seeing what's coming from the neck. When we superimpose them, we can see which one is the earliest one and which one is the latest one. That's why we superimpose them, and the computer measures that automatically and tells it what it is. So now we're done with the median nerve. We did the sensory fibers, the motor fibers. Now we're going to do the ulnar nerve. We've already done the sensory fibers. We're going to do the ulnar motor. And I press next, and now I have ulnar motor left, so now I'm in the right place. I'm going to take these off here. Again, I'm still using the same electrodes. They have enough glue on them. I put it right where I marked up the spot. Okay, and I take this here off and I put it on the baby finger, and I'm going to stimulate the ulnar nerve at the wrist. Here we go, and here's the stimulation point, so I do it like so. Now first thing, we see a response coming up here. I go up higher because I want to make as big a response as possible. And the ulnar usually has a response like this that has two bellies. That's normal for the ulnar nerve. It's not abnormal. So that's the wrist response, and I saved it. And now the computer identified it, and it tells me that this is the beginning, this is the peak, and this is the return to baseline. And in the ulnar nerve, because as you know, if you've hit your crazy bone, most ulnar nerve problems come at the elbow. So I need to stimulate at the elbow. In the ulnar nerve, I stimulate at two places at the elbow. The first thing is below the elbow, and the second thing is above the elbow. Now, why is that? If you have a problem here at the elbow, right, the conduction from here to here is going to be okay, unless the nerve is very damaged. That's another story. But if the nerve is not completely severed or not completely damaged, if I stimulate from here to here, it's going to be okay. It's when I stimulate from here to here that the nerve is going to go through the elbow and be slowed. So that allows me to localize the nerve lesion at the elbow, essentially. So for the median nerve, I stimulate in two places if I need to. I stimulate at the wrist, and if I need to, I can stimulate at the elbow. For the ulnar nerve, I always stimulate at three places. So wrist, below, and above the elbow. And again, I use set distances, and these set distances for the elbow is 12 centimeters across the elbow. So here we go. And what I like to do is to measure the nerve 2 centimeters below the elbow. So I put it at the elbow groove right here, okay, and I mark the 2 centimeter point, and 10 centimeters above. So this is 10 centimeters above the elbow, this is 2 centimeters below, so from here to here is 12. Okay? Again, I have normal values for this, that's why I use that. So let's see. And like I said before, the response from the wrist above and below the elbow in normal subjects has to be quite similar, otherwise there's a problem. So now let's stimulate below the elbow, which is right here. Okay, and I'm going to see if I can show you this without my hand being in the way. Right here. And so below the elbow, the nerve is deep, so sometimes you have to use more electricity. Let's see, and your arm is going to jump because we're going up higher now. And now with more electricity. Here we go. And we got it. So that's the response below the elbow. I accept it. You see, it's very similar to the one at the wrist. Okay. And now we go above the elbow, which is right here. And we stimulate it again. And usually above the elbow, the nerve is closer to the skin, so I decrease the stimulation a little bit. But you're going to see it again. Here we go, and I got a nice one. And that's the stimulation of the ulnar nerve at the wrist, below and above the elbow. The only thing that's left for me to do now is to tell the machine what is the distance from here to here. from below the elbow to the wrist, because I know that it's 5 centimeters from here to here and 12 from here to here, so but I don't know this, so that's the one I'm going to measure, and I'm going to take it from here, and it tells me it's 23 centimeters from below to the wrist. And look here, I'm going to input 23 centimeters here, 230 millimeters, and it's going to tell me that the nerve is conducting at 60 meters per second for below, I inputted the wrong numbers here, 230, it should be. And here the nerve is telling me that from the wrist to elbow, it's conducting at 59 meters per second, from the wrist to below elbow here. And from the elbow to arm, it's conducting at 60 meters per second. And usually, she's super normal. Usually this is not that close. Usually the velocity here is higher than the velocity here, because everybody bangs their elbows. So she is very normal in that sense. And that's the ulnar nerve study motor at wrist, below and above the elbow. So the next thing for the ulnar nerve, we're going to do the F wave. Again, when I stimulate the nerve here, the electricity is going up and down. And the way we display it on the screen is going to show me where the F wave is coming from and where the distal stimulation is coming from. So now I'm going to press next, and that's going to show me the ulnar F wave. Again, here I'll be looking at the response coming from the wrist. Here I'll be looking at the response coming from the neck. And for the F wave, like I said before, we always stimulate at the wrist. Okay, I'm going to try to get my hand out of the way here. Here we go. So I'm going to use some electricity, and again, I want you to squeeze the ball. You can ask them how much money they owe on their credit card. That always does it as well. Just distract them. So here we go. And I don't have it. I'm not using enough stimulation. Now I'm using enough stimulation. Look, I'm beginning to see the F wave. I'm going to give her a bit more to see if... Now I'm still growing here. A bit more. Okay, so the response is not growing anymore. So now I'm going to accumulate the F waves to superimpose them. Here we go. Squeeze. Look at these nice responses. You see those F waves that are coming up? Very, very nice. And I would give her about 10. It's counting 8, 9, 10. And that's it. And now it superimposed them. It told me that the minimal latency is 25, which is normal for her age and her height. Now, having said that, if patients have a problem in the neck or the back, this may be a flat line. The F wave may be absent, or it may be delayed. So always look for an F wave to be present, number one, and always see how often do you get it, because if you have a bad lesion on the neck or in the back, you might not get it at all. If you have a mild lesion, you will get it, but it will be delayed. So that's what you'll be looking at for the F wave. Okay, so now we finished the upper extremity. We're going to do the lower extremity. The lower extremity, we do 2 motor nerves, the peroneal motor and the tibial motor, or posterior tibial motor. And we do the sural sensory and superficial sensory. And then we do the H reflex. We might not do all 4 nerves all the time, but I'm going to show you the nerves that we do on a routine basis. The peroneal motor, obviously, and the tibial motor, we do an F wave. For the sensory fibers, we do not do F waves, just like in the upper extremity. So I like to start with the sural nerve. And the sural nerve is right behind the malleolus here, right behind this bone. It comes down from the calf down like so, curves around it and goes around the foot. So I'm going to measure it right here. And what I'd like to do is to put the points where I'm going to put the active electrode, the black, and the reference electrode, the red. And I measure 14 centimeters from the active electrode up to the ground, up to the calf. And this is marked here, 14 centimeter for sural nerve. So I do this here, and I mark up the spot where I'm going to stimulate the sural nerve. And here we do. And now I loaded the left lower extremity nerves, so it's given me the sural sensory left. Here we go. You're going to feel this after I start stimulating. But before I start stimulating, of course, I need to put the electrodes on. This is the black, connected to the black. This is going to connect to the red, and this is the green. And I'm going to put it between the stimulator for the time being and the electrode that's going to be connected to the black or active electrode. So let's connect the green here, like so. Actually, let me reverse that to make it easier. Connect the green, okay, that's the ground. Connect the black, that's the active electrode, and then connect the red, and that's the reference electrode. And one thing I find very useful in the lower extremity is to ask the subject if they feel the electricity going down their foot. If they feel it, that means you're stimulating the nerve. If they don't feel it, that means you're away from the nerve. So I like to do this, to ask them this, because that gives me good feedback. And here I'm putting the stimulator over the point, 14 centimeter point above this. So now you're going to feel this. I'm going to start stimulating. Again, in the beginning, you're not going to see too much of a response because the nerve is not being stimulated. Then I raise it up a little bit. Again, are you feeling this going down your foot?
A little bit.
Okay, so let's do here. How about now?
Yep.
You feeling it more? Okay. Here we go. You're going to begin to see a response here. That's the green one. Yeah, actually here, this way. And here is a very nice response, and I accept that. And that tells me that the sural nerve was stimulated properly, and the machine put the cursor here for the onset or distal latency, 2 for the peak latency, 3 for the return to baseline. And then you can read it here. It has an amplitude of 14.6, a latency of 3.0, and now, because we said that the distance was 140 millimeters, it's telling me that the velocity is about 46.7 meters per second. So that's the sural nerve in the lower extremity. So now we're going to do the superficial peroneal nerve. It's a sensory nerve, branch of the peroneal nerve. For that, we're going to put the electrodes exactly the opposite from the sural. For the sural, we put it behind the malleolus. Here we put it in front of the malleolus and the ground in between. And now we're going to measure 12 centimeters. That's the distance that I use because I calculated normal values based on that. From the black to right here, the middle of the leg, right in front of the calf. Okay, and that's the 12 centimeter point. And that's where I'm going to stimulate the nerve. Here we go. You're going to feel this. Now I don't see it. Here we go. Now I start seeing it. Now I see it. Too much electricity. And I go back to where I was before. And I accept it. And it found it. Now note that the third point here, the computer placed it here, that's not here. So I'm going to move it. I'm going to say this is where this thing is located. And that's going to give me all this reading. And it's going to tell me what the distal latency is, what the peak latency is, and what the return to baseline is. And I'm going to read all these values out here. And that's the superficial peroneal sensory. The next nerve we do in the lower extremity is the peroneal nerve, the peroneal motor this time. And the peroneal motor we record from a muscle called the extensor digitorum brevis here. This is the muscle here, and that's really the dorsum of the foot. It bumps up when you ask the subject to point their toes towards their nose. Now relax, point your toes up, relax. You see, that's where the muscle is. And as I see it contracting, bend your toes up. I just place an X over that, and that's where I'm going to place the black electrode to record from it. That's the black electrode. That's the active, okay? Then I put the reference over a neutral area, and I put the ground here out of the way. And now I need to measure the distance that I use to study the peroneal motor. The peroneal motor, I measure it at 7 centimeters, and I put it from here. The peroneal motor is really in the middle of the ankle, somewhere here. So I place this here. And for the peroneal, like for the ulnar, we do 3 stimulation points. Because sometimes if you cross your legs and if you cross them very hard, you might or if you lean against a sharp object, you might actually damage the nerve right here, right below the fibular head. The fibular head is this bone that protrudes out of the knee like so. So below the fibular head, the nerve may get compressed, and so I want to study the nerve below the fibular head and at the knee above the fibular head. So if the nerve is okay from here to here, but not okay from here to here, that means there's a problem at the fibular head. That's called peroneal neuropathy at the fibular head. I'll measure that in a moment. And here I feel the fibular head, and I want 10 centimeters above. Don't ask me why. This is how the normal values were collected. Elbow I use 12, here I use 10, just to confuse people. And then we measure 10 centimeters here, and that's where I stimulate the nerve at the knee. So now I marked up the stimulation points for the peroneal nerve. And the computer is set up to record the peroneal motor. And like we did in the upper extremity, I want the response from here to look like the response from here, to look like the response from here, obviously if the subject is normal. If you have a problem between these responses, if one is lower than, let's say, this is normal, but this is low, that means there's a problem here. So that's why we try to study it in more than one place. And now we're going to stimulate the peroneal nerve at the ankle, which is right here. You're not going to feel this. Okay, here we go. Now you might start feeling it. And here we go. We got a response. Let me see if this is the maximal. No, it's still going up. No, that's maximal. It's not going up anymore. So that's the response from the peroneal nerve at the ankle. Now the next thing we do is accept it, and the computer tells us where it started, the amplitude, and the return to baseline. It tells you the latency is 4.10, the amplitude is 8.12, and so forth and so on. So the next place where I stimulate the peroneal nerve is below the fibular head, right here. And I place it like this, and again do the same thing. I'm still at the same stimulation amplitude here. And beautiful response. It looks almost the same. The leg jumped, obviously. It looks the same. And you see here it depolarized the nerve. You see the nerve the muscle beginning to respond right about here. But now that I went up all the way to the almost below the knee, it's taken much longer to get here. So now I accept that, and I want to go to behind the knee. Okay, and you're going to feel that as well. And I stimulate. Here we go. That's maximal, and I accept that. And these responses look the same. You notice, and the patient felt it, that we're using a lot more electricity because the nerve is deep here. Okay? Now we know that the measurement from here to here was 7 centimeters or 70 millimeters. And between here and here is 10. We still don't know what it is between here and here for the computer to calculate the conduction velocity or the speed between these 2 points. So now I'm going to measure this. And it's telling me that it's 30 centimeters. I enter that right here. And now it's telling me that the conduction velocity from the foot to the head of the fibula ankle is 47, and from above to below is 41. That's still within normal limits. It's usually slower here because people cross their knees a lot, or they might bang it against a sharp object. Next, we do the peroneal motor F wave, stimulating at the ankle. Again, the F wave always from the distal stimulating point. And I raise it up here. The F wave is coming from the back this time, not from the neck. And I start stimulating. And I'm getting a nice response here, but I'm sure not maximal, so I raise it up some more. Now I'm getting a better response. Raise it up some more. Okay, now I'm getting an excellent response. So I'm going to start looking at the F wave, which is here, and that's coming from the back. And I'm going to give her the ball to squeeze again. And I'm going to start collecting the F waves again. Here we go. Let's go. So that was number 1. Squeeze. 2. Look how beautiful when she squeezed. 3, 4, 5, 6, 7, 8, 9, 10. And I accept those, and you can stop squeezing. And the computer immediately reads the shortest latency F wave. That means the fastest F wave to see if these fibers are being compressed or entrapped or they're being damaged. If you have no F response or a delayed F response, that means that there's a problem in the back or in the sciatic nerve somewhere else above the knee, essentially. So you either have a delayed F wave or an absent F wave. In this case, they look normal. The next nerve we're going to study in the lower extremity is the tibial nerve, or posterior tibial nerve, because it's in the back of the leg. And the tibial nerve I studied here right below the ball of the foot. So I put the active electrode right here below the ball of the foot, right there. And I put the, I don't know if you can see it well, but I put it right there. And I put the reference electrode right over this bone here, the ball of the foot. And I measure a distance of 14 centimeters. And the tibial nerve I stimulate right here. Okay, so now I need to measure 14 centimeters. Put that mark over there. And relax your foot. Excellent. And now we are positioned over the tibial motor left. So I'm going to stimulate here. I'm going to try to get my hand out of the way, like so. And I'm going to increase the stimulation a little bit. You're going to feel this. We're going to start seeing a response. Here we go. That's the response. Nice response. Nice response. Still growing. Not growing anymore. And that's the posterior tibial nerve motor response. And I look at it. It's giving me all of this information about it, the latency, the amplitude, and the duration. We can also stimulate the tibial nerve from the knee to calculate a conduction velocity. I don't usually do that frequently because sometimes it's very difficult to stimulate at the knee, and a lot of time it doesn't really give you a lot of information here, but I'm just going to do it. And again, what I'd like to do is to get a response that looks similar to this one, and I go to the back of the knee right here, okay, and I'm going to start stimulating. Here we go. Here we go. Here we go. Now we got it. Nice response. Okay. And we accept it. And again, they look exactly the same. And I like them very much. So I'm going to measure that. And I measure it exactly from the place that I stimulated to this point here. And it's reading 35. Okay. And I'm going to put 35 here for the distance. 350, that is. And it's going to tell me that the conduction velocity is 45.8. And it tells me that the latency from the ankle is 6.25, from the knee is 13.9, the amplitude from above and below, and also it's telling me what the conduction velocity is. So, now that we're done with the tibial motor study, we're going to do the tibial F wave, and I stimulate the tibial nerve at the ankle right where I stimulated it here for the distal study for the conduction velocity at the ankle, and I put it here. And remember, I'm looking for the response from the foot here and the response from the back right here. I'm going to give her a bit more electricity. Here we go, and I don't see a response here, so I'm not stimulating the nerve yet. Okay, I'm not stimulating the nerve yet. Now I'm beginning to stimulate. Look, I even see an F wave, but it's not maximal. I'm gonna get it higher. Oh, look, she has beautiful F waves there. So now I know that they exist. I'm gonna start accumulating the F waves so that I can analyze them. Now squeeze on the ball. Here we go. Here we go. 3, 4, 5, 6, 7, 8, 9, 10. And I accept those. And now the computer identified which is the shortest latency here. See, it marked it up F1. That's the shortest latency. That's really not an F wave. That's movement artifact here. The computer was able to identify that this is artifact here and picked up the right one and tells me what the F latency is. in this case is the minimal F-wave latency, 38.5 millisecond. And that's the tibial motor F-wave. And now we're going to do the last nerve in the lower extremity, and that's the H reflex. The H reflex actually is a reflex. It was discovered by someone by the name of Hoffman in 1918. That's why it's called the H reflex. And the H reflex also goes up to the back and comes right back down. So the H reflex, in addition to the F wave, tells you whether there's a problem in the back or not. The difference between the F wave and the H reflex is that the F wave just travels over motor fibers, so it tells you if there's the motor roots are involved. The H reflex travels over both sensory and motor fibers. So if you have a pure sensory lesion causing a lot of pain but no motor lesion, the H reflex is very helpful. If you have a pure motor lesion without a lot of pain, the F wave is very useful. We usually do both of them, of course. But that's why we use the F wave and the H reflex. When we do the H reflex, we have the subject laying on their belly, as you see, with their feet hanging over the bed. The reason for that is because we want their calf muscles to be relaxed. And in fact, that's where we record the H reflex from the calf muscles. So basically what I do is I ask the subject to press on my hand as though they're pressing on a gas pedal, and I feel the space right between the lateral gastroc and the medial gastroc, which is right here, and that's where I place the black active electrode. The reference electrode, I place it a little bit below that, right here, maybe a little bit further down to make sure I get a silent area. And the green I put between the stimulating point and the active recording electrode. And then I study the H reflex, and again here, you're going to see the response coming from the calf, and here you're going to see the response coming from the H. Now I have to tell you, with the M wave, with the F wave, you see a very, very nice motor response here. With the H reflex, you want to see a smaller one. The reason you want to see a smaller one is because you really want to study the sensory fibers first. So I'm trying not to get as good a response, believe it or not, on this side. I'm trying to get a great response on this side first. That's the difference between the H reflex and the F wave. The second difference is that the F wave is very small. The H reflex, as you will see, is very big. It'll be much easier to identify. And finally, if you have one nice or two nice H reflexes, you don't need to get 10. So here we go. We're going to stimulate at the knee, right here. Okay, and she's going to feel that. Here we go. And I want you to focus on the screen. And let's see. Again, I'm looking for a small response on this side and a large response on this side. So look at that. Beautiful response. Again, nothing, very small on this side, very nice response on that side. See how big this is compared to the F wave? It's a very big response. So I just go up a little higher again. And I got a beautiful H reflex, and now I'm going to stop. I'm going to accept it. And the computer superimposed all these H reflexes that I got and told me what the latency is and what the amplitude is and what the duration is. And she has a beautiful normal H reflex. Normally in both lower extremities, I do the H reflex on both sides because I want to compare latency on one side to the other. If you have a nice H reflex, you're going to get it very quickly. If you don't, you're going to struggle with it. And be careful, because it might be a big F wave that looks like an H reflex, but the dead giveaway is that the response on the left side here is going to be small as opposed to very, very big with the F wave. And now let's look at some normal and abnormal nerve conduction samples. Let's talk about the sensory potentials. This is a very nice sensory potential here, the one that's surrounded by the O, P, T, and R. We'll talk about those a bit later. Usually you'll find the sensory potential in the second or third column. In the first column, or in the beginning of the first column, you see this big spike. That's a shock artifact. The shock artifact is the fact that you have delivered electricity to the nerve, and that electricity was transmitted to the machine, and it displays it as this big spike. Ignore it. Sometimes you cannot ignore it because it's so big if you're using too much current that it will include the sensory potentials in it. It'll be very tough to distinguish when the sensory potential started and when it's finished. But anyway, you should always look for the shock artifact, make sure it's separate from the recording, and make sure that you can nicely identify the takeoff and the return to the baseline of the sensory potential. The O stands for onset. That's when the sensory potential leaves the baseline. The P stands for peak. That's when it peaks. The T for trough. That's when it returns, or the bottom of the sensory potentials. Notice one thing, that the O and T are sort of symmetrical to the P. They're almost at the same level, the O and the T. The R is when the potential returns to baseline. Look at what you see on the right side here. That's a motor artifact. When you deliver a shock, you produce movement as well. You're not just stimulating sensory fibers, but also motor fibers. And that movement produces this waveform on the screen. This is too big to be a sensory potential and too late, too far away. As I said, the sensory potential is usually in the second or third column. Some people find this very quickly and they take it as and measure it as a sensory potential. Of course, that is wrong, because it's easy to see and because it's easy to measure. Now here's another example of a sensory potential here. You see that we still see a big motor artifact, but you see here that the O and the T are not symmetrical. The T is at the bottom. The T should be where this red arrow points to. Because if you leave the T at the bottom, by the way, this is what the machine set it up as, but you have to override that cursor setting, because if the T is at the bottom, it's showing you that the amplitude, that's the distance between the P and the T, which is the amplitude of the sensory potential, is double of what it should be. So you really should reposition the T to be symmetrical to the O in order for you to be able to measure the amplitude correctly. The R is okay and the O is okay. As I said, there's this huge motor artifact on the right side, again because of movement. Ignore it or try not to produce it, essentially. Here's another example. Remember I told you about the shock artifact. When it's too big, it engulfs the sensory potential in it. Here it's very difficult to tell where the sensory potential started. You can see a little bit where it ended, obviously. You can for sure see the peak. But it's tough to see where it started. And the machine indeed went and put the O at the bottom. That's not true, obviously. The O probably should be here. I'm guessing here. But that's where the onset probably is. The P is where it should be. And because the O and the T are preferably symmetrical to each other, I would put the T where that red arrow points out to. The things on the right are motor artifact. Again, we're just delivering too much current here. You really should stop when the sensory potential peaks and when you're producing the least motor artifact possible. Here's another example here. What did we do? Even though the shock artifact is not too big, the machine for some reason picked the onset in the wrong place. It picked the T about in the right place, certainly the R in the right place, but certainly not the O. The O, in fact, should be here. You can see a clear deflection from the baseline when the potential starts to go up. And here you should override the machine and put the O where the red arrow points out to. Here's another example. This is a pseudosensory potential. You can see it's a small potential. It's still within the second column. And you see a very big motor artifact right after that. Here, the only thing I would adjust is the R for the return. Obviously, it's not returning where it says it's returning. It's returning where this red arrow is, most likely. Again, there is a motor artifact here because, again, we use too much current, and you should avoid that. Here's a typical example, of somebody who's a beginner, and they didn't get a potential in the second column where we usually should find it. So they found this nice waveform to the right. You can easily see the O, you can easily see the P and the T, and we put it there, and that was called the sensory potential. Obviously, it is not. There's an absent sensory response here, and what they measured is a motor artifact that is too far away. Now, here's another extreme example to the left side, in which there's a big shock artifact, and the machine measured the O, the P, and the T in what seems to be a sensory potential, but it really is not. This is part of the shock artifact. the sensory potential is probably where that R is. And obviously, I would move the O, the P, and the T in that direction. Is that really the sensory potential? I bet it is. It's a bit delayed. It's in the beginning of the third column, but it's certainly not the one that it's measuring. So if we were to guess, the onset is probably here, the peak is probably here, and the trough is probably here. That's what I would take. The return obviously is very easy to guess. Here's another sensory potential. Also, it's a low amplitude sensory potential, the O, P, T, and R. And the sensory response is okay. It is a small response, but it is okay. You still see the motor artifact here. You may not be able to get rid of the motor artifact, but you want to really minimize it as much as possible. Here's another example, but you already know that. It's really measured it wrong. It's not the sensory potential, it's a motor artifact, and it's happening too late and it's too big, basically. Here's another interesting one. I haven't seen too many of these, but the operator here, also a beginner, found that, well, you know, that's a waveform. I can probably see the peak, I can probably see the O, I can probably see the R, and put it there. Of course, it's nothing. This is just a little baseline move, and the sensory response is absent here. And there's no motor artifact, and it's a very bad cursor placement. That response should not be read. It should be read as a non-response, essentially. I want to show you an example of, you know, a low sensory potential. Again, it's still in the second column, so because it's low, it doesn't necessarily have to move to the right. You can see the O, the P, and the T in the correct places. You can see the R where it returns to baseline, also in the correct place. It's a very low sensory response. If it's totally, it may be absent, in fact. I'm just guessing that it's there. But at that level, absent and very low means the same thing, essentially. And the cursor positioning is okay, obviously. Here's another low sensory response, but it's still present. And here's another low sensory response. The reason I'm showing you all this is because you can have very low sensory responses. Notice in all of these pictures that there was no big motor artifact because the technician stopped. They said, well, if I go up higher, I'm going to get a motor artifact, and I'm probably going to suppress the sensory response because it's going to be eaten by the motor artifact, so I'm going to stop there. So that is okay. It's okay to do that. Now here is a great sensory response. You can see the O, the P, the T, the O and T are symmetrical. The R return to baseline is correct. That should be your template. That should be the picture in your head about what a sensory potential should look like when it is normal. Obviously, we've seen the abnormals as well. And here's another sensory potential. It's a bit further to the right. In the middle of the second column, ends in the middle of the third column. Potential cursor positioning are great as well. Now here, I'm not going to throw this out. You know, there's of course a motor artifact on the right, but I'm still able to distinguish the O, P, and T and R, and they're in the right position. So I'm not going to get rid of that either. Okay, now we're going to start with the motor potentials. You'll find that they're a bit less troublesome than the sensory potentials because they're much bigger. Here, for instance, is a nice motor response from the left tibial nerve. And the motor response, you'll notice immediately we record from 2 points in some places and from 3 points in some other places. In the tibial nerve, we record from 2 points. You'll see that in the DVD that we sent to you and in the measurements that we indicated on how you should record and stimulate. Here you see that the response from the ankle is a big, nice response. You can see that the machine identified the onset, the peak, and the trough, and the return to baseline. You can see that when you go to the knee, you get almost an identical response. It's a bit lower amplitude. The most important thing is that the ankle and the knee look the same. It's very important in motor potentials to be sure that the distal, that means from the ankle or the wrist, and the proximal, that means from the knee or the elbow, look the same. Because If they don't, that means that you're stimulating more than one nerve or even a different nerve, and therefore recording from a nearby muscle, not from the same muscle, and then all of your measurements will be wrong. So it's very important to be sure that the distal and the proximal response look the same. Now, it will not always be this way, because if there's abnormality, then the distal and proximal response may not look the same, and that's part of the problem. But under those circumstances, if you increase the current just gently and gradually, you will start seeing when the response stops looking like it, or when the response doesn't grow anymore, or where the response immediately jumps to a different response, that you're now stimulating another nerve. We'll talk about this later. But here I just want to make sure that you see that the distal and proximal response look the same, and see the nice cursor positioning that the machine has placed on these potentials. Obviously, as I pointed out before, the knee is slightly smaller because we're stimulating at a greater distance from the muscle. Remember, if you're stimulating at the ankle, it's very close to the muscle. If you're stimulating at the knee, it's further away from the muscle, so the response is going to be smaller. And that makes sense. It's normal, but it looks the same. It's a great motor response. Example in which, again, from the tibial nerve, look, the responses look the same here. But what is the problem? The problem is that the knee response is much smaller than the ankle response. That means we found the nerve because we're getting a response. We're stimulating it in the right place, again, because we're getting a response. But guess what? What is it that we're not doing here? We are not using enough current. Under those circumstances, what I would do, I would keep the stimulator right at the knee, right where I have it, and start increasing the current. And by increasing the current, I'm going to increase that knee response to have an amplitude that will match the ankle response, not reach it, but match it. It'll be a bit smaller, as we showed in the previous slide. So just more current. Oh, here's an obviously abnormal or artifactually abnormal recording, not abnormal. The technician got a beautiful response at the ankle and no response at the knee. What happened there? It doesn't make sense unless the nerve is cut and was cut yesterday, because if it was cut for 7 days or more, you will no longer be able to see that response at the ankle as well. But there's no at the knee as well, but there's no response at the knee. What happened here? Either the technician did not use enough current, was in the right position and did not use enough current, or the stimulator was not in the right position. So at that point, what I would do is I would move the stimulator first, just move it around on the knee until I start getting a response. And once I get a response, even small, I start increasing the current. So not enough current or a bad stim position will give you this sort of an absent response, artifactually absent response at the knee. Now here's another interesting picture. This is the peroneal nerve. Again, as I said before, in some nerves you stimulate in 2 places, some nerves you stimulate in 3 places. Because the nerves that you stimulate in 3 places, you usually do so because they can get entrapped at one of these 3 places. Peroneal nerve is one of them. The ulnar nerve is another one, as we will see. But here's a nice peroneal recording, a normal peroneal recording. You can see the responses at the ankle, below the fibular head, and the popliteal fossa, which is the knee. A look the same. B have very similar amplitudes. That's a normal response. Again, note that they are a bit smaller as you go up because you're further away from the muscle. But the response looks similar. The positions of the cursors, by the way, which is much easier to identify because these are motor responses, they're big. Positions of the cursors are excellent. The O, the P, the T, and the R, everything looks perfect. When you see that, that's a normal recording. It's a great motor response. Now look here. What happened here? Here we get a response at the ankle, and we get a response at the popliteal fossa, which is the knee. Well, that doesn't make sense, because if you can stimulate at the ankle and you can stimulate at the popliteal and record a response, you really should get a response at below the fibular head. It's absent in this one. What happened? Well, again, when the technician put the stimulator at the fibular head or below the fibular head, the technician didn't either did not use enough current or didn't put the stimulator in the right position. So move the stimulator a little bit, get a response, even small, then begin increasing the current, and that's when you're going to get the below fibular head response. It doesn't make sense to get a response at the ankle and at the popliteal fossa and not get one below the fibular head. It doesn't make sense. You should go back and retry the stimulation position by changing the position of the stimulator and then increasing the current. Here's another response from the peroneal motor. What's wrong with this one? Well, it doesn't look like too many things are wrong with it, except that we only see two responses, the ankle and below the fibular head. What happened here? The technician did not do the knee. So anything that happens between the below fibular head and the knee, we're not going to be able to tell what it is because the technician didn't record that. So you always should record three responses: ankle, below fibular head, and knee for the peroneal nerve. Now notice, on the other hand, that the responses look similar. The cursor positioning is good. And notice that the response below the fibular head is a bit smaller. In fact, I would have used a bit more current. So again, they look the same. But the knee is absent, not stimulated, not studied rather than absent. And obviously, because of that, we cannot calculate the velocity across the knee in this case. Now, I pointed out to you that even though the potentials at ankle, below fib, and the knee or popliteal fossa should look the same, sometimes when there is abnormality, they don't. Here's a perfect example. This patient has a foot drop and a peroneal neuropathy. So you see there are three responses. At the ankle and below the fibular head, they are fairly similar, fairly close in amplitude. The positions of the cursors are fantastic. What happened at the popliteal fossa? The nerve is, the response is spread. We call that a dispersed response. The amplitude is lower, but if you see the first elements of the response where the O, P, and T and R are, it's beginning to look like the ankle and the knee, and then it stops looking like them. What this patient has is a compression or entrapment or pressure or injury or lesion of the peroneal nerve between the popliteal fossa and the fibular head. So when you stimulate below the fibular head, the response is normal. When you go above the lesion, which is between the below fibular head and the popliteal fossa, you are now going across the area of the lesion, and of course the response is abnormal. So that's a peroneal neuropathy between the fibular head and the popliteal fossa, and the recording is abnormal. It shows a low amplitude and a dispersed response. So that is abnormal, and that's where you lose the relationship between the waveforms. In other words, they don't exactly look the same anymore, and the amplitude is lower. This is a peroneal neuropathy. In this case, we're going up to the upper extremity. You see the median nerve, median motor. Again, if you recall, the lower median nerve is a nerve that we stimulate in two places, the ulnar nerve in three places. You see very nice responses, and you see that the cursors were placed properly. The responses look the same, slightly lower amplitude at the elbow. Nothing wrong with that. And it's a great motor response. This is the ulnar nerve. Like the peroneal, we stimulate it in three places: at the wrist, below the elbow, and above the elbow. Because if you have an injury of the ulnar nerve, the great majority of the time it's going to be at the elbow, so between the above and below elbow segments. Here you see that the response looks nice in all three locations. They're similar, amplitudes are a bit lower, and the cursors are well positioned, and it's really a great motor response. Now, let's go to the F waves. F waves are these small motor responses that you see after the motor potential, and that you study after you've done the motor response in a nerve, because the F wave goes all the way back to the neck or to the back, namely to the anterior horn cell, and comes back. So it's very useful in root lesions. Now here's a very nice F response. You can see that there's a nice motor response or M response on the left. And you can see that it's reproducible throughout all of these. And you can see that we see these small motor responses far away because they are coming from the neck or the back, from the motor neuron in the neck or the back. And so they take a long time to arrive, basically. So they are much more delayed than the M response. And in this case, as we normally should do, the technician obtained 11 traces. Normally we should obtain 10 traces. If we don't find good F waves, we go on and get 11 or 20. But a minimum is 10. And you can see that the cursor positioning was great. In other words, it identified the shortest latency F wave, and it says this is where the shortest latency F wave is, and that's the latency that we should use, because F waves have different latencies, and our normal values are based on the shortest latency F wave. So you really have to position that where you think the first F wave has appeared. Now, what about this? What's wrong with this recording? Well, for one thing, I don't see an M response here. I don't see a motor response, at least in the first few traces. Then I start seeing a very small motor response. What's going on here? So basically, we either didn't put the stimulator on the nerve, or when we put it on the nerve, we didn't use enough stimulation, enough current. And that's why we could not get a nice M response. Therefore, these responses on the right that were thought to be F waves are not F wave. They're just squiggles. They're just movement. They don't mean anything. You should not use these as F waves. If you go down these columns, you can see an F wave here. Now that's a real F wave because it's preceded by an M response, albeit not a good M response. And now you don't see other good F waves. So in this case, either the stimulator was not located over the nerve, or if it was, the technician did not use enough current to stimulate it. So that I would not use that. In fact, I would not use that F wave because I'm not sure it would be the short latency anyways. Look at this. You would say that this is probably a very good F wave, and I agree with you. But what is wrong with, well, let's see what's right with it. The M response is great. We can easily identify the F responses, and we can easily identify which one are the shortest latency. What's wrong with this? Yes, only 7 traces were obtained. We should get a minimum of 10 traces. So could you be right in measuring this? Yes, you probably may pick up the shortest latency F wave. Are you always right? No, because sometimes you'll identify the shortest latency F wave late in the process, and so you really should get 10 responses before you start measuring the short latency F wave. I would be willing to bet that in this case, the patient was complaining about the stimulation and the technician has stopped and figured that they could get an good enough response. If that happens, that's fine. But if you can go for the 10, go for the 10. How about the H reflex? This is a very nice H reflex. You can see that response very clearly. You can identify the takeoff, and you can position the cursor right there. Note very easily that there's either a small m or no m. Unlike the F, it's best to obtain the H reflex, or the H reflex is best obtained when you don't use that much current, or at least enough current to get an M response. And here you either have a small m or no m, and you have a huge H. Those are the ideal recordings to measure the H reflex and to identify the H reflex from. It's a great response. Now look at this one here. Again, I can nicely see the H reflex, but note that the H reflex has a lower amplitude here. Why? Because we start to see a nice M response on the left. The greater the M, the smaller the H. The smaller the M, the greater the H. So could you still measure the H reflex? Yes. Is it ideal? No. What I would do under those circumstances is turn the current down a little bit and so that you can get a smaller m, and then that h will get bigger. It's still a good h reflex, but I would try to get a smaller m. Now here's the point I was trying to make. If you keep on increasing the current, you get a very nice m, and it's a huge m in fact. And guess what? This is not an h anymore. This is an f wave. You're just doing an f wave study. You cannot use this as an h. Here's a response where the m wave is small. I mean, I would use that, either small or absent, but in this case, there is no h reflex, and we should not measure that. This recording will be called an absent h reflex. All right, so now we're done with the upper and lower extremity nerve conduction studies. We used the routine sets of nerves that we do in the upper extremity and the lower extremity to explore the most common conditions that we encounter, namely carpal tunnel, upper extremity pain, ulnar neuropathy at the elbow, wrist drop, sometimes brachial plexus injury. In the lower extremity, more commonly than not, peripheral neuropathy, low back pain, and so forth and so on. And you've seen the muscles. Again, we do sensory nerves and motor nerves. And motor nerves we do F waves with. In the lower extremity, we do sensory nerves, motor nerves, and F waves and H reflexes. A lot of times you can do the nerve conductions alone because they will tell you what's wrong with the nerve. For instance, peripheral neuropathy, ulnar neuropathy at the elbow, carpal tunnel entrapment, and so forth and so on. If you have any questions, you need to do a needle exam to see if there's something else that you're not suspecting could be present but could be causing the symptoms essentially. One more thing I'd like to mention is that make sure you have good normal values that you are using, because you are always comparing the patient's data to a set of normal values. So make sure that you are using the same techniques for electrode positioning that were used to collect these normal values, so that you compare apples to apples and origins to origins. Finally, one more thing, make sure that the extremity is not cold and warm it up using a hair dryer or washing their hands in the sink to make sure that you don't get artifactual slowing. Thank you very much.